Hi everyone. Thanks for joining us today. We have another scientific webinar for 2026. So just a reminder, general housekeeping as usual. You'll be on mute joining. But we also enjoy your participation in this. So we're going to let Kenichi go through his presentation, and then we'll have a time for questions at the end. But if there's anything that kind of catches you as you go along, please feel free to use the chat, and then we'll use the kind of the raising hand feature at the end to ask any questions. And just a reminder, in this case, we are recording this webinar, which will be going onto YouTube at a later time. Just to introduce today's speaker, I'm sure many of you know of Kenichi and his work. He's a distinguished science and sub-lead in ADME pharmaceutical sciences at Roche. And leads a team specializing in vitro PK DDI and in vitro sample bioanalysis, and as well as large molecule research, and supports portfolios throughout discovery and development phases to final submission. And I'm sure most of you will be aware of his experience in clearance prediction and DDI risk assessment, especially in translation using PBPK. And that's generally the topic that we asked him to present on in his recent publication, looking at the DDI risk assessment for Vicasinabin. That's right. Thank you. Yeah. And the impact of the 2C19 genotypes. So without further ado, I'll pass over to you, Kenichi. Thanks again for agreeing to talk.
Yep. Thanks a lot, Oliver. Then
thanks.
Yeah, thanks. Then I hope that I can present the first title slide of my presentation today. Is that right?
Yep, we can see.
Yeah. Thanks. Yeah, thanks a lot. Thanks again, Oliver, and everybody there for providing me that opportunity to present or share one of the case example how the Roche use the PBPK modeling, especially for DDI risk assessment, and also that before entry in human stage. This is really prospective DDI risk assessment of our one of the portfolio compound, Vicasinabin. And also that major focus is how to evaluate the impact of CYP2C19 genotypes on the PK and DDI risk as an object. And before starting this presentation, that I want to thank you for all the contributed to that work from preclinical and clinical area at Roche. So this slide summarizes the drug disposition of Vicasinabin. And this compound has been developed for the treatment of diabetic retinopathy, and oral route is considered. And you can see that right-hand side of this slide, and this summarizes the drug disposition of this compound. And this compound shows the high solubility and high permeability properties. In that sense, we don't expect any limitation in terms of FA, and actually you can see already the predicted FA numbers here based on the physical chemical property, which is 98%. And this compound is also optimized to show that moderate or low the metabolic turnover. In that sense, we don't see much contribution of intestinal phosphates or hepatic phosphates. And you can see the predicted FC and FH number is quite high, and the resulting in the high oral bioavailability here. And once this compound is get into the systemic circulation, based on the in vitro the data that we expect, that kind of compound is eliminated by the CYP enzymes and some UGTs. And you see especially CYP3A contribution and 2C19 contribution had been expected. That means this compound is a dual substrate of CYP3A4 and CYP2C19. And of course, the early stage, we don't have any quantitation of that fraction metabolism relative to the total clearance or metabolism. And the project team's concern is that CYP2C19 genotype, how this impact on that PK and the victim or object DDI risk assessment. And turned out to be the precipitant DDI risk assessment part for this compound. In vitro data shows the induction frag for CYP3A4. Already that's the full kinetics tells Emax and EC50 shown here. And even that we see that the weak in vitro induction potential for CYP2B6 and 2C8. And we couldn't get any full kinetics based on these enzyme induction, but this is also that the project team's concern at early stage. And also for the transporter, this compound shows the moderate to weak, the IC50 values on these transporters, hepatic active uptake transporter OATP1B1, intestinal PGP, and renal OCT2 and MATE. And these are kind of the general concern that's before going to the human entry in human study. Of course, that the team's major concern is that how the impact of CYP2C19 polymorphism on the object DDI predictions. And also sometimes we know that in vitro in vivo correlation for such a CYP2C19 mediated clearance is not the perfect sometimes. So that's we decided to run the PBPK modeling at early stage before entry in human to characterize DDI properties as much as possible we know. And of note, all simulation studies were performed prospectively. And once the respective clinical data are available, we compare that clinical data relative to the modeling. So then that modeling, modeling predictivity is confirmed later. So this is really prospective assessment. But also, even though that we want to explore the object DDI risk assessment, so how was that impact of strong, moderate, and weak CYP3A4 perpetrators on that, the Vicasinabin PK, and how was implication of the further impact of CYP2C19 polymorphism on the object DDI predictions. So this is the major concern to be addressed for the team. And of course, that we have the other consideration because this compound shows some precipitant DDI risk anticipated. So we also did the PK prediction and also perpetrator and standard victim DDI risk assessment due to CYP3A4. You can see that bottom part of this slide. So we also did that prospective simulations, and especially these data as predictions are compared with the clinical observations. And then we use this as kind of confirmation. And if this confirmatory work is working well, in case that we go to, or we believe that CYP2C19 polymorphism impact assessment could be reliable. And yeah, I think the model verification part, if we go into detail, yes, the first one is SAD-MAD, PK profile prediction, and second one is the itraconazole DDI risk. This rather confirmed that the object DDI risk assessment predictivity of our model, and also that's the midazolam DDI risk assessment, which is rather precipitant. That means how Vicasinabin induce the CYP3A4 enzyme and impact on the midazolam. And atorvastatin is rather focusing on OATP1B1 and PGP inhibition and metformin, of course, inhibition effect of Vicasinabin on MATE and OCT2. Yes, that's the preclinical stage. Of course, we run that static DDI risk assessment before going to the PBPK modeling. And preclinical PK-PD relationship, first we anticipated the human dose is around 42 milligram. However, that's based on discussion and want to see that's the maximum tolerated dose. We want to increase the dose up to the 300 milligram. So we run that static DDI risk assessment starting from 42 milligram and up to 300 milligram and in between 100 milligram. And the easy way plot is that transporter inhibition risk assessment, and we really take the ratio, R value, or the concentration relative to IC50 ratio according to FDA or EMA guidance, because this time we didn't have that any ICH-M12 document, so we follow the FDA and EMA guidance. And you can see the red numbers only available at 300 milligram. That you can see that the right-hand side row. And then that we see that some fracking numbers or ratios here. However, these numbers are really close to the threshold. So in that sense, if we think about static DDI risk assessment always provide worst case scenario, then shouldn't be the clinical relevant. However, that team was decided to run some of the clinical DDI study and confirm that this borderline static DDI risk is not of any clinical concern. So enzyme part, the somehow extrapolation is the challenging. So anyway, that's we decided to go that midazolam clinical DDI study and not much invest on the static modeling. But here that you see the summary for the CYP2C, 3A, the induction potential here that you can see the in vitro Emax EC value and also calibrated Emax EC value has been, listed here. And they come back to the 2B6 and 2C8 induction. So this is not our major topics today. However, we also run the induction DDI study on the bupropion and rebaglinide, and we couldn't see any induction effect of Vicasinabin. However, that's because of lack of the calibration, the in vitro induction parameter to the in vivo, then we didn't further investigate PBPK modeling strategy, rather directly going to the clinical study data. So maybe I would close this CYP2B6 and 2C8 story and more focusing on that other perpetrator also going to the object DDI risk assessment, the CYP2C19 polymorphic impact on that. Yes, this is the PBPK modeling workflow. That's the phrase in the previous slide. The first that we try to establish that PBPK model of Vicasinabin by using the in vitro or preclinical data, and we don't adjust or optimize any the input parameters. And then for absorption, we followed Adam model. Maybe that absorption is not the key issue for this compound because of the high solubility and high permeability, but we took Adam model, and for the distribution, we took full PBPK model. And first, we prospectively predicted PK simulation, and then you see the two branches here. That's the first one, left-hand side, is the precipitant DDI risk assessment that try to see the prediction of how Vicasinabin impact on the midazolam PK due to CYP3 induction, atorvastatin PK, mainly due to OATP1B1 and PGP inhibition, and also that's on the PK of metformin due to OCT2 and MATE inhibition. And the object DDI side, you can see the right-hand side of this scheme. Then we try to investigate or predict the impact of itraconazole, which is strong CYP3A4 inhibitor on Vicasinabin. And this orange part, later we get the respective clinical data, and first that we confirm that this model prediction is really great. That means retrospective modeling work is good or not. Afterwards, that we go to the victim DDI simulation, which is untested case scenario. That's the green one. Then that we want to see that's how that moderate, weak, or strong 3A perpetrator impact on the Vicasinabin PBPK, and also try to see the impact of CYP2C19 genotypes on the victim or object DDI risk assessment. So this is the flow to catch up here. And then starting the simulation and to address the primary question from the team at Roche, that we want to integrate CYP2C19 genotype information in the population file. And at that time point, we picked up several papers here that to characterize this part. And our focus is much more on the only 3 haplotypes, STAR1, which is wild type, STAR17, which is increased activity, and NU, which is loss of function. And we know that 2C19 genotypes are really complex. For example, that's stated here, for example, STAR2, STAR3, and STAR4, that these are also identified as new genotypes, but we also merge this old frequency into that one new population. That because of this, the prospective modeling perspective, we don't go into the deeper side, or we want to avoid some complicated investment on that population file. So then we try to merge some of the genotypes into the several ones. especially these three the haplotypes, and then that try to estimate frequency as shown here in the table. And also we have another paper that the hepatic CYP2C19 activity and variability within the genotypes, using the genotypes human liver microsome, and there's the paper also that shows that the in vitro S-methanogen metabolic activity. So these information, you can see the right-hand side of these table. These are included in that population information. Then going to that, the verification part. And then again, that we compare that our PK prediction first, and then that these data are compared to that clinical data when these data are available. And here is AUC and Cmax, the comparison, and on day 1 and on day 14 after multiple dosing mode QD. And you can see AUC and Cmax shows the more or less linear trend, and also that within the twofold error predictivity. And then that this shows our model is really capturing the PK profile of this compound Vicasinabin. And you can see that the right and bottom side on day 14 Cmax, you see 200 milligram QD and 300 milligram QD. We may not see the linearity of the Cmax increase over the dose. And we see that the 300 milligram QD Cmax is overestimation somehow. Then even this compound shows high solubility, but solubility limitation starts at this level of the dose. However, other than that, our model captures the PK profile quite well. Then this is another confirmatory study, how our model captures precipitant DDI profiles. And panel A represents how the Vicasinabin captured the change of the PK of midazolam due to the CYP3A induction. And then this means that we dose the Vicasinabin for 14 days, and the day 13, midazolam microdose, which is 100 microgram, is dosed on the single dosing mode. And then we see that the difference with and without Vicasinabin treatment for the midazolam. And you see that the induction effect is well captured here. And for the panel B and panel C is the transporter inhibition study, Vicasinabin and metformin dosed on a single dosing mode at the same type of Vicasinabin dosing. This is single dose DDI, and we don't see any change of the PK profile of atorvastatin and metformin. And then this means that the borderline static DDI flag due to the transporter inhibition cannot be channeled to be the positive. This is also something for us, the gain. That's all the time we are talking about borderline static DDI risk flag, and this is finally confirmed that static modeling is kind of the worst case scenario to evaluate transporter DDI. And as the side note, we also simulated the impact of the multiple dosing DDI of atorvastatin and the Vicasinabin. And then you can see the table, the bottom on the right-hand side. The AUC ratio of atorvastatin is a little reduced, and AUCR is below 1. This means the 3A4 induction effect of Vicasinabin and the impact on the atorvastatin PK is well captured, because atorvastatin is also the substrate of CYP3A4 beyond OATP. However, that we couldn't have this clinical data, so we cannot confirm that. But this tells the Vicasinabin CYP3A4 induction effect is surely modeled in the right way. Sorry. And this is another aspect of the CYP3A4 induction prediction. And then we also did the dose-dependent induction effect of Vicasinabin and impact on the PK of midazolam. All designs are same in the clinical setup. The Vicasinabin dose 14 days, and at day 13, the midazolam dose was dosed at 100 microgram, and we changed the Vicasinabin dose. So you can see that AUC ratio change, observation and prediction in upper panel, and lower panel, the left-hand side, you see the Cmax change, and observation and prediction are also listed. And we really capture dose-dependent induction effect of Vicasinabin on the midazolam PK. So this theory provide us a confidence that our model is really capture the Vicasinabin PK and precipitant DDI profiles. And turning to the object DDI, we want to see how our model predict the impact of itraconazole on the Vicasinabin PK. And AUC ratio as observation is around 2.2-fold, and which is also that's comparable to the prediction, which is 2.6-fold. And you can see that we cannot capture the full profile of Vicasinabin. However, the AUC ratio and Cmax ratio are well captured. So considering that the use of this model, the before entry in human stage, coming back to that's the primary question from the team, I think that the PK profile was not well captured or perfectly captured, but that does the job to address the question. That means that we can predict or estimate the risk of CYP2C19 genotypes on the PK profiles. And this itraconazole data also provides some justification. FM CYP3A4 is well captured in that model. Then using the healthy volunteer population, that we try to see that's the kind of the object DDI risk assessment, how PK profile of Vicasinabin is changed in the presence of the several CYP3A4 perpetrators. I think the interesting case is fluconazole prediction, that you can see the middle of the first plot, and AUC ratio predicted of Vicasinabin with co-dosing of fluconazole is around 2.3-fold, which is close to the level of itraconazole DDI effect. We assume that fluconazole is the 3A4 moderate inhibitor, but if we go to the table right-hand side, fluconazole is that's also the CYP2C19 inhibitor, so dual inhibitor for CYP3A4 and 2C19. In that sense, this additive effect of inhibition may increase that AUC ratio, that which magnitude is close to the itraconazole DDI level. So to confirm this hypothesis, we see that the AUC ratio of Vicasinabin with erythromycin treatment, which was predicted that 1.75-fold for the AUC ratio. And this is a lower compared to that case of fluconazole or itraconazole. Erythromycin is purely 3A4 inhibitor. So in that sense, this AUC ratio prediction difference can be coming from this, the dual or single pathway inhibition effect of the precipitants. On fluvoxamine, you see that AUC ratio, which is 1.2-fold, the slightly AUC of Vicasinabin is increased by that treatment. And again, fluvoxamine, of course, this is a weak CYP3A4 inhibitor, however, also showing some inhibition effect on CYP2C19. So this CYP2C19 inhibition effect can be or could be piled up to that simulation. And efavirenz and rifampicin, we all know these compounds are that's a dual inducer on CYP3A4 and 2C19. And here AUC ratio and Cmax ratio are coming from dual effect on these two enzymes. So then that we are now see that the confirmation of the model. Our model is quite okay, but this is that's interesting prospective work. But when we did the simulation to address the question from the team, that we don't have any clinical information. So this is very interesting case. And then anyway, that we jumped into that the question. That's how we want to address to the team the CYP2C19 genotypes impact on the Vicasinabin PK. And here is some exaggerated case, because in the first slide, we saw that the Vicasinabin is also the substrate of UGT. But in this simulation, I omitted that UGT contribution and tried to exaggerate CYP2C19 impact that for the team in terms of worst case scenario discussion. And you can see the panel B, the star 1 population, the CYP2C19 contribution is around 31%, and star 17 and star 17, which means increased the CYP2C19 activity, then the relative 2C19 mediated clearance contribution is increased. And of course, that if we go to the null population, that means we don't have any CYP2C19 activity, then 3A4 contribution is 100%. This is extreme case. However, you see it comparing that panel B and panel C, the CYP2C19 contribution is only slightly increased, and then we easily expect this can be hidden by some variability in the clinical setup. Actually, you can see that PK profiles here, left-hand side, and across that some star 1, star 17, null population, we may see some that's the half-life change. However, that this also can be hidden by the individual variability. So we usually conclude that CYP2C19 genotypes may not impact on the PK of Vicasinabin. Actually, that's a confirmatory study here that we checked that how the dose normalized AUC or Cmax can be correlated to that CYP2C19 genotypes from the clinical phase 1 study over the different dose of Vicasinabin. And the clinical people set up some the threshold and they define extensive interim, poor, rapid, and ultra-rapid metabolizers. However, we don't see any correlation of that AUC and Cmax value over that the different genotypes. And this also is supported by that PBPK modeling data. Then that we go to that exploring untested case scenario or exploring case scenario, that how that the other strong or moderate the CYP3A4 inhibition, the impact on that Vicasinabin PK and in the context of the impact of CYP2C19 genotypes. And the upper panel, again, the itraconazole DDI simulation data, but selecting the different CYP2C19 genotyping populations. And in the middle, null population, that we expect no CYP2C19 contribution and more CYP3A dominating to the total elimination pathway, plus some UGT contribution. And then AUC ratio predicted is around 3.7-fold, and which is the maybe highest one compared to the other populations. And then if you go to the right-hand side, star 17, and then that in the presence of itraconazole, the AUC ratio is increased 2.3-fold because this population has increased activity of CYP2C19. So relatively, the 3A4 contribution to the total clearance is less. In that sense, the AUC ratio or impact of itraconazole is weaker compared to that in the null population. However, this AUC ratio change or difference is also minor. So we also easily conclude that this cannot be the clinical relevant, or we don't see this difference in the clinical setup. And the same tendency was observed for erythromycin, the lower panel. This is, that is, if we go to the null population, AUC ratio is 2-fold, which is highest again. And then star 17 and star 17 population, which is the right and bottom side, AUC ratio predicted is the 1.6-fold, and then this is lower. So this is same tendency for the itraconazole. And then that same exercise was done the CYP3A4 perpetrator, but also showing the dual CYP2C19 inhibition or induction effect. Left-hand side table is representing inhibition DDI, and right-hand side represents induction DDI. And the left-hand side, okay, that we can go to the predicted effect of fluconazole, which is dual inhibitor on 3A and CYP2C19 on Vicasinabin. And you can see that some red characters, the star 17 populations, again, this means the increased CYP2C19 activity. Then we see that AUC ratio of Vicasinabin has been predicted as the 2.5-fold. However, if we switched off the CYP2C19 inhibition potential by fluconazole, this is one row below, then that AUC ratio predicted is 1.66-fold. So this means the obvious some CYP2C19 inhibition DDI plays a game. However, again, this difference 2.5-fold and 1.7-fold. Again, that we may not identify this kind of the difference in the clinical setting, but we see that some difference in the theoretically. And the same exercise was done for the weak CYP3A4 inhibitor fluvoxamine, and showing the strong inhibition effect on CYP2C19, and same tendency was observed by using the star 17 population. And for induction, you can see that the right-hand side and bottom row in the table, we see that impact of rifampicin. Again, that we picked up star 17 and star 17 population. So you see that AUC ratio, Vicasinabin with co-dosing rifampicin predicted 0.2-fold. However, if we switched off CYP2C19 induction effect function from rifampicin model, then AUC ratio is a little bit increased 0.28. Again, that CYP2C19 impact is somehow that's negligible in the clinical setting, considering about variability. But theoretically, that we could successfully show that how that's the CYP2C19 genotype impact on the PK profile and object DDI risk potential here. So this is the conclusion. The team's concern, especially at early stage, that's the minimum, that's how the CYP2C19 genotype impact on the PK and DDI risk. And the team concern is that sometimes CYP2C19 FM estimation is not the reflecting from in vitro data. However, that we want to try to show that the minimum impact of that genotype on the PK and DDI risk assessment. And this theory that brings forward or justification that we can also go to the phase 1 clinical trials based on this assessment. And also kind of in the process of addressing this question, that we could run the PBPK modeling to predict PK profile and other victim DDI risk potential, and also precipitant DDI risk assessment. And this is kind of, for us, that's a good asset. That's after comparing all clinical data with the prediction and showing that the PBPK modeling of this compound works well. And this is kind of negative data. That means CYP2C19 genotype contribution is not much hooked up. This is good for the project team, but we believe that if we have some compounds showing the relatively high contribution of CYP2C19 to the total clearance of metabolism, we can use that the PBPK modeling approach, even support the pre-entry in human stage with the help of PBPK modeling. So I think that's all from my end, and thanks a lot for your time, and I'm happy to take any question. Thanks a lot.
Thanks, Kenichi. Has anyone got any questions they want to raise? I think that's a really important point about the 2C19 and how you could apply it across different projects. In terms of, obviously you presented the impact of using the induction as predictions, particularly for rifampicin. Mm-hmm. So you ran it with and without the 2C19 induction, and in this case, I guess it didn't have a massive impact. Mm-hmm. In terms of the final decision, was it kind of assuming the worst case with that induction, and what kind of induction parameters did you kind of settle on for that? Did you just settle on what was in the file, or did you have to do some additional work on that?
I think that's this time we just use the available rifampicin file. That's where the CYP2C19 induction parameter is already in. And because, yes, again, this is very early stage, and we don't want to go into detail to justify or adjust the CYP2C19 induction parameter. Of course, and on top of that, the CYP2C19 induction potential is relatively lower compared to CYP3A4 induction. So in that sense, that we don't want to invest for this characterization at this stage. But of course, definitely, if we go the late stage, that was the final submission, maybe that's we have the room to discuss this part.
Mm-hmm. Thanks for clarifying that.
Thanks.
Any other questions from anyone in the audience? I can't see any more, but thank you, Kenichi. I appreciate you taking the time to take us through this case study, and I'm glad that the modeling helped in this application
Thank
as
you
well.
so much.
That's always a good story to tell. So just to wrap up, just to make you aware that we have another webinar upcoming in the 10th of March. We have Julia McKenty from J&J, and she's going to be talking about some work she did prior to joining J&J on predicting drug transfer to human milk with the SimCyp simulator, part of contribution from the conception project. So feel free to register for that as well. But finally, I just say thank you everyone for joining, and then finally thank you again to Kenichi for giving us that great presentation. Thank you.
Thank you so much.
Goodbye.